Good morning for all around the world and welcome to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at Mount Sinai Hospital in New York. My name is Dr. Pedro Moreno. I'm Professor of Medicine and Director of the Cardiac Catheterization Laboratory at Mount Sinai, St. Luke's. The video of this broadcast will be available at the website later today. Now, the video of our last broadcast from August 13 and all our previous structural heart cases are available at our website, cccomplexcases.org. We'd love to hear from you. So send us your questions right away from the website. Now, we have a fantastic case today. This is an amazing case. And let me transmit directly from the cath lab to the Mount Sinai Hospital right now to my colleagues, Dr. Sharma and Dr. Kinney.
Okay, everybody here, welcome from Mount Sinai Cath Lab for our episode of this structural heart live case. And as Dr. Moreno just mentioned, the interesting point is we know the TAVR has become a routine procedure, but alternate access or more difficult vascular access is a big issue nowadays, knowing that more and more patients are undergoing TAVR procedure, knowing that it has been approved in almost all the risk groups. So clearly we need to master our vascular access skills, which of course there are very alternate access, which I talk in my further discussion. But we just welcome everyone and we start our case presentation because we are ready to show it from the cath lab with Dr. Kinney on my left side, Dr. Gilbert Tang on the right side. We're actually introducing our new structure attending, Dr. Sahil Khera, and we have our fellow, Dr. Parasuram. And then Dr. Stam is on echo, and you'll be hearing it, Stam right here. So all that, welcome.
Can we focus on Dr. Sahil Khera?
They're doing it. Yeah. So everyone all ready for Mount Sinai Cath Lab for this our episode, and we'll go through the slide presentation and we'll take you through this case and then actual performance which we have been doing now. So these are our disclosures. Next. No, what did you get? Dang us. Pedro Moreno. Next. Okay. This is the patient, 91-year-old. As you can see, patient is worsening, dyspnea on exertion, and class 3 for symptoms for our last few weeks. Patient has been on IV diuretics and thoracentesis requiring, and patient has multiple risk factors. And basically, as you can see here, the patient is on good medical therapy, and patient has already the normal sinus rhythm, and T showed a severe calcific aortic stenosis with a high gradient, and we'll just go through the our echo actually. If you get, see that here, very calcific aortic valve with a high velocity, with the peak velocity of 4.2, high gradient, and significant severe AS with valve area of 0.8. Next. And now the echo, I'll ask Gilbert to just go through it.
Yeah, so these are the CT dimensions you can see here. The perimeter is actually a little bit borderline between a 26 and a 29 Evolut Pro. You can see the area is 6 centimeters square. The aortic root is pretty reasonable with the angle 54. You can see here very generous sinus valsalva. The sinus height is plenty. And also you can see the LVOT is actually larger than the annulus. And I think based on that, we're going to have a discussion, but likely we're going to probably go upsize to a 29 Evolut Pro for better seal in terms of reducing peripheral leak.
So therefore, I think many times it's a question whether we use a 26 or 29, and what we learned in this field is okay to oversize it, and particularly with a self-expanding valve. So, so when there is a question based on the vascular anatomy and rest of the factors, the decision may change. Even you started with a 26 and then go with a 29, and we'll go through this. That is that the right decision, and of course with the case particularly. Yeah.
So you can see the access in this case is particularly challenging. You can see very calcified vessels, iliofemoral, both throughout on the right side and the left side. You can see here as well, actually Dr. Khera will explain about the access, what side we choose, but I just want to show you and appreciate that. And this is the sizing chart for the Evolut-R Evolut Pro here. So here we want to comment about the access when we just go back to the previous slide.
Yeah, so if you look at the right side, it narrows down to a segment which is 4.3, and the iliac is consistently railed with calcium. that makes it very challenging. If you have no calcium, you can still do a 5-0 vessel and go up with your equipment.
And show it here now.
And
So what is exactly is in this case? We have taken some pictures.
so,
Angiogram.
Yeah.
So yeah, this access will make us definitely want to use Evolut-R because of the two French reduction over the Evolut Pro.
so you see the left side has less calcium overall. And look at the calcium on the right side, all the way.
This is the right iliofemoral.
But show the picture of the artery on the left side. There's a right.
Let's play this.
The right is more calcified.
Yeah.
And okay, good.
So we,
So you see
even
that
though we use
narrowing?
CT, you can see Dr. Clara here, Sahil, show that the right side is more calcified. So sometimes we have the game time change decision because of this.
Left side picture, left side.
Left femoral, iliofemoral, yeah, here. Good.
So that's our stake. We want to make sure when we stake, there's no calcium around it. We park a wire because it's complicated and challenging access. We went up and over, put a wire there, and then put a micropuncture, made sure we stick around 60 to 70%. And then we do our angiogram, which confirms that the stick was dead center, relatively free of calcium. Both the percloses took pretty well.
Okay. So now then question comes, it looks like a very large lumen. The indication for what we have advertised today, that we'll use a
Shockwave lithotripsy.
Yeah, that should be used it because of this calcium, because knowing that we know on the CT, the vessel size is just at the borderline.
So actually the narrowing is at the iliac level. So it's just about on the right side was like 4.6 and left side just making it 5 with lot of calcium. But same, not circumferential calcium, it's calcium on one side of the vessel. That's why we decided we will use a shockwave lithotripsy, and after that we will use the inline to go up with this valve. So I think if we can show the size we took with the balloon is the same. With the lithotripsy balloon we have a 6 centimeter.
No, go.
Oh, we have the picture there?
Do we have
we have a
of the balloon?
Yeah.
No, but we have alternate accesses, yeah, but not exactly the picture right now. But yeah. No, but we have the balloon. Show it here.
Yeah.
Right here.
No, not anything.
Huh?
No, they have not.
Put the light
Yeah.
on.
Yeah.
Yeah. Yeah. This is the balloon. Yes.
It's a 60
they zoom in?
millimeter length.
They can zoom it.
Can they
6 centimeter and
sure they can.
with the diameter 60 millimeter length.
We need
So
to
essentially
zoom.
what
We
we'll
need to
do-
zoom the camera, SS. We need to zoom it so we can see it.
Yeah.
Can we do that?
Very good. Very good.
Okay,
We
there
can
you go.
see it
Yeah,
there.
Yep. Yep. And the device also on that side. I'll show actually. I have the picture of the device, and so a little later as the mechanism in my presentation. But this is the actual
There
balloon.
you go. Perfect.
And the
So
idea is,
essentially you'll see it will be emitting shock waves from all this where you see these pointers that you see. So we will show exactly how it's being done. So we will go, ready?
Yeah.
We'll go up now.
So this is 014
ACT?
compatible.
Did we give more heparin yet?
Yeah.
Yeah. You gave, Rafi, you gave more heparin, right? After the 297?
Fluoro.
Huh? Just one, yeah. 2 more, please.
Little more.
Here?
A little more. Yeah.
Okay. So I'm going to just do a dry cine.
Let us know when
Right.
it's given.
Okay. The amount of, right?
Come on, yeah.
Calcium there, yeah. Let's connect.
let me just show one slide. We'll show it and we'll go back to our usual presentation later.
Can the camera be focusing here? Go up 4 atmospheres.
When time comes, we'll show this picture. And then will be the
Okay.
Great.
So
Okay, you just see the dog boning. Let me take another cine.
Yeah.
Yeah.
okay. I'll tell you show this slide. When I tell you show this
Okay,
slide,
we ready?
show this slide.
For
Which
the
diameter is this balloon?
6 centimeters.
6 centimeter.
6 meters. Yeah.
Millimeter,
Ready?
millimeter.
Okay, go.
6 millimeter, yeah.
Millimeter. Yeah.
And lengthwise and length
60.
it's a 60-60 balloon.
60.
6 and 60. So while they're, you see this now, can we show that slide? Just to say that what are those markers and those where the will be emitting.
Yeah,
just show
this
that
is what
slide
it was.
on the main.
That was a slide
Yeah.
which I was
Yeah,
talking about.
See, those are the various markers, and this is where the ultrasonic the wave comes out. And play the next lower one, the video, that how it's basically like a jackhammering on the road. So just causing the slit-like fracture in the calcium, so your subsequent balloon. See that like explosion.
6 now?
Yeah.
Calcific explosion makes the micro, and of course
Okay, we
peripheral, they have been tested quite a bit, and the coronary trials are ongoing at present with the name of Disrupt. Disrupt CAD has been 2 done outside, and 3 is a registry of the calcific lesions ongoing in United States, and hopefully will show the positive result. And then we have IVL, intravenous lithotripsy, that's what they're going to call it. Intravascular lithotripsy, IVL, will be available for clinical use, we expect, in United States in next 2 years, as long as the data shows good with the trial.
Okay.
Yeah,
So we started at 4, we went up to 6 atmospheres, now we are going up to 8 atmospheres, okay? And then we have done
2
2
cycles.
cycles. Yeah, first cycle was 30, it gives you the timing. So if they can see that, and now 60, and then you were going up again.
So basically, this acoustic bubble induces a cavitation inside the balloon that is transmitted to the vessel wall without
Do
dissection.
we
So
need
low
to
pressures
go to a different
are good
segment?
enough. And as Dr. Sharma mentioned, the initial results of the coronary cases are actually pretty encouraging, with allowing the interventionalists to deploy the stent without under-expansion. But peripherally, it's a tremendous advantage that will allow us to advance the device for the TAVR.
Okay, then how long we have to leave it at any
No,
given
we're done. Wait. Go to something else. Now, done. Now again.
Yeah, you want to go up?
Good.
Let's
Now
go
we
a little
go.
more proximal.
So we are done at that particular site. If you see here, can you, okay, you know what, go up. You can see the dog boning effect is gone. The vessel is nice, expanded. Yes. So this is a cine. Nice. Okay, down.
Beautiful.
So we are going to move up a little bit. Deflate.
That's nice.
Okay, yeah, right here. Agree?
It looks good.
Okay, good. Now you go up. 4, yes.
Yeah, it's still there.
Yeah. Okay, now we are going to start again. Come here, 4th cycle, press. Go. Okay, I'm going to press again. This is the 4th cycle. I think we're done after this. We don't need anything more.
Yeah, and maybe
What
we
you're doing,
can,
What is the cycle? How many seconds?
No, it tells you.
we can also
yeah,
show the console, Dr.
30.
Kinney.
Show the console. He wants the console.
Sorry, you want to see the console?
Yeah.
No, it's
Yeah,
hard.
show
The
the
camera
whole
cannot move to that
system.
side.
That's okay.
Okay, we'll show it 1 second. So we have done 4 so far, right? 30 seconds each. We did 4. So that is what the goal is the same. You place it one particular area, then you give a 30-second cycle, and you can go to a maximum of 6 at a particular spot. So we gave 3 in a particular spot, then we moved up to this spot. So we have done 4, but looks like it's a good expansion. The dog boning effect is gone. See that you can go 6 to 8 atmosphere. We should be done here. Everybody agrees?
Yes.
Team?
Absolutely.
Okay, down. So we if I show the console,
Yeah, we had
then
to show the console.
no, hold on. You give it to me, then I have to unscrub again. Can the camera show this?
Yeah.
Yeah, we can see it. It's a very simple and easy to use device.
So you see here, this is a number.
Bring that on the center screen, please.
So it gives you 30 seconds. So 30 into 4 we gave. So 120 seconds is the total we had given, right? Yeah. Yeah. Okay, good.
Beautiful.
Now I have to unscrub
So
Please
total 120 second only.
today.
Yeah,
But you can go max of
Yeah.
6. At a particular site, max of 6.
180. Okay.
Give me the air mod, please.
All right.
IOR.
So this is to facilitate. You know, we did on last year on December 6th as part of our New York valve. We did the very difficult case for the right iliofemoral calcific. Size was 4.8. Did a repeated lithotripsy of the right iliofemoral, and then we were able to insert the 14 the inline sheath and did the TAVR. So that was a very again unique technique. Now there's some data have been published now. We have our own experience. This adds to you that how can you do the femoral, because that is the biggest thing. I will show briefly some data that where the outcome of the TAVR really gets superior to surgery is when you do a transfemoral transiliac. Sorry.
So we used a Grand Slam wire for the Shockwave. We're going to swap it out for a super core for the big sheet.
Which one?
One more. Okay, good.
Okay, we're going to cross the valve. Right?
Yeah. Where's the no, not yet.
No, we're going to put the sheet.
The big
first.
sheet.
First the sheath.
Yeah.
Change it.
Where's the up and over?
And sheath size will be
We have it.
14 French.
Yes. That's a super core wire, just for support.
Okay.
I got.
Have wire? Cam?
Because Evolut-R and Evolut Pro, although has a little advantage Pro because of additional cuff, but it adds 2 French to the size, becomes 16. And Evolut-R will be 14. Patient with a vascular disease issues, like this case, we'll just go with the 14.
Neck out.
Okay, you want to see the, and see the sheath going in. That's the key. You'll be holding it, right?
Yeah, I'm holding pressure.
You can make out more.
Pressure for a second.
Okay, good. Slowly.
Wow.
You want to go with
Should
the
we have done
dilator
that?
first again only?
Yeah, that's it.
Okay, going first.
So just sometimes spinning it softly helps.
Yep.
We're negating the bend there. And just gentle
Wow.
traction on the wire. You
Yes.
guys can see how challenging that is.
Many times we actually lubricate the sheath with the rotaglide.
Maybe we should.
Or
do-
leave off head.
Should we propofol?
No, sheath-
Propofol.
Should we do that?
Oh, propofol?
No, we're good. We're good.
Good.
We're done now.
Yeah.
This is the inline, but we need to do the inline afterwards.
Yeah, but not glide. You want to leave off head, use it.
No, propofol. Can we get some propofol?
Propofol. Don't. It's very expensive.
Yeah.
Which is expensive.
Yeah. Let's get some
Rotaglide.
propofol, please.
What's this
Stir up propofol.
propofol?
Okay.
That's in a cup.
Okay, what's the plan now? What are you doing?
We got to cross the valve now.
Okay,
For
good.
the inline.
Yeah?
Okay, the plan is to do the balloon valvuloplasty?
Yes.
Yes. We'll cross first.
Yep.
Has
Keep going.
like go ahead. Okay.
Okay.
Has moderate AI. So Damien, get me a thoracic Landerquist, please.
No, but why Landerquist will need?
Just for the inline, we'll need a little more support.
I see. Okay, here. This is the valve. You want to check the gradient? Aorta is okay, and femoral has no.
Now we have the pigtailist. We have pigtail in the ascending aorta.
Yeah,
We're just
but I
going to
think we
cross
need-
now?
Otherwise, you see, you go. Do we have to stir up
I'm
propofol?
cutting down one more mag.
No, no, that's
No?
okay.
Okay.
Don't keep changing.
Very calcific.
Go LAO.
One of the challenges, you see that loop recorder there is kind of in our way of our implant angle. We'll show you later on what we had to do to try to overcome that.
Oh, probably that view was better, right?
Let me go less mag, right?
That's it.
Good.
I don't understand. You guys have been changing the magnification
Good. Okay. Let's
multiple
connect
times.
Which one?
Anyone?
Okay. Sheath, the flush. Lot of flushes. Okay, check the gradient. Okay.
Can you show the gradient?
Yeah, but flush this one too.
Is there?
Yeah. Yeah.
So even after sedation, you have a significant gradient across
Gradient,
the
yeah.
aortic valve.
Okay.
Yep.
Let's go. Keep
Unnecessary.
Yep.
Okay,
Yep.
get us.
Yeah. So now we trying to put our exchange length wire so that we change it to the pigtail and get to the
Exactly.
apex.
Okay, you want to go to
RO view now.
Careful that wire, bent.
Useless.
Hmm?
Useless.
Ah,
Good.
wire is bent.
Actually, position is very good right now.
Yeah, but we need the pigtail to.
Yeah, this is the extra step which we actually, once we adopted this, we had a rare cases of LV perforation has eliminated, that you go with the soft, your 35 exchange, put a pigtail, and then put the confida wire. Okay, keep going. Just look at the tortuosity. Even the wires and the pigtail going up now.
Right, let me go further.
That's it.
Good, very good.
Where did you
Lunderquist.
want to leave the Lenderquist?
No, not yet. We'll see.
Yeah,
Oh, we are using
yeah,
Lenderquist today.
because of the tortuosity.
Okay, not the usual
So we
confida.
usually use the confida for typical TAVR cases, but you can see how this extreme tortuosity and calcification on the iliofemoral and the abdominal aorta, it makes it more favorable for us to use a Lunderquist double curve that allows you we've also in addition pre-curve the soft portion so that we can make sure that it sits in the ventricle nicely.
Okay. Yeah, I just have to be very careful with the Lenderquist. You know, it's a very stiff wire.
Yes.
And particularly by alternate access subclavian, there showed cases with it causing a dissection, severe.
You
Looks
okay
very
with the
nice.
curve?
Yeah.
Oh, hold the sheath.
Good. Curve looks good. Okay, valve is ready. Good. No, I know. Before BAV, make sure always that the valve is ready in case patient develops severe AI and hemodynamic collapse. So valve should be ready at this time, which is, they already have checked the orientation. And the alignment. Okay, go. I see that the pigtail which was curved has become straight with this Lenderquist. This is the 20 millimeter.
Okay, no
Z-Mag.
pacing, just go.
Okay, go.
Go up. Uh-oh.
Good.
Okay, good. This is the BAV. Okay, coming out.
Okay, so the BAV is done.
Okay, go negative here.
Yeah. Good. Okay, I'll hold it.
Okay, okay, okay. Who has the wire?
I have it.
So let's mag out and hold the pressure on the groin. This way to take the inline,
Okay.
take this out for the
Good.
inline.
Got the valve now?
If we needed inline, why did you go with the 14 French sheath?
No, but you have
Yeah,
to
no,
do a BAV.
this is for the BAV.
BAV.
Yeah.
Okay, ready?
Okay, go ahead.
Okay.
But you didn't need
Okay, we
14.
will take the sheath out now.
Okay.
Now you see here, so we have done the BAV. So idea is so that now we can put the inline sheath of the Evolut,
Let's
which
mag
I
out
hope
too.
they change soon.
Mag out, please.
With the engineering development, they should be able to detach the sheath. Unfortunately, they don't have that mechanism yet.
Let's look at the
But that's
groin.
a very simple thing to do. If you can detach the sheath, you can leave the sheath in and we don't have to go through this extra process. And then if you need to put an additional balloon, will be fine. But now, even if you require post-dilatation BAV after the TAVR, you have to put back the sheath again, your 14 French, and then do a BAV. Okay.
So I guess this is the most important step to see how the valve navigates through the iliofemoral system that previously we saw that the sheath was very difficult to advance.
And in the
So-
curve was, yeah, okay.
So 3 o'clock.
So you go about
Okay,
30
go down.
degrees there,
Fluoro.
Yep.
under
Then hold
fluoro.
it like that.
The Lendequist is a much better wire that will give support for this device. And as Dr.
so far
Kinney is
pretty
showing, that's the area where difficulty may arise. It's going
pretty
very
smooth,
well.
little
Pull the
crunchy
wire
there.
gently.
Now
No,
you
but
have
we
to
have to see
see
the
the
top
wire, yeah,
Yeah.
Top wire
wire in the
also.
ventricle.
Yeah,
Yep.
good.
Yeah, perfect.
Now I can
perfect.
pull a little bit, yeah.
Yep.
But this
yep.
had to be a bird's eye view of both.
Gentle
Yeah,
spin.
and you have to just spin it gently, as Sahil mentioned before, so that we can navigate this calcified and tight turn portion. Good, getting there.
Beautiful. Yep. And very, very careful so don't
Wire,
dissect.
wire.
Wire,
Yeah.
wire, guys.
Good. Good.
Okay.
Okay, that's a
Leave it,
lot
leave
of
it.
extra slack. See that?
Okay,
Yeah,
so
yeah,
this
yeah.
part is done. So now let's see.
So let me help it. Let me help it. Okay.
Up.
Okay, go.
Okay.
Good.
So let's make sure the orientation.
Good.
1 second. Let's. This is the other turn
That's
that
the
is difficult.
second
turn.
part happened with the arch. Okay.
Okay.
Then we
good.
go to regular mag.
Yeah.
Nice.
And your
Okay.
pigtail.
Now we did not use
On the
sentinel
non now.
because
What?
So first we have to take the parallax out.
we wrote down sentinel possible.
Yeah, beautiful.
No, mag 1.
And what happened is they found quite a bit of subclavian tortuosity, so we did not use the sentinel.
Yeah.
But otherwise, sentinel device has become a default option in our all TAVR cases at Sinai, and which should be like other places also, unless there is a contraindication. Knowing that
Ready?
the sentinel
Cannot see
trial
iota, nothing.
did show
Can you
reduction
go better?
in
picture?
map view?
severe, more I would say neurologic strokes, although and the small lesions, although non-significant,
It's
but
not.
clearly we have seen
Inject-
that once you use a sentinel,
Yeah, deeper.
the type of stroke patient
Very
develop is
high.
really
Yeah, it's
small,
high.
if at all.
So
Okay.
not too, yeah.
I
That's
went in
disabling,
because
yeah.
it was minus.
Okay.
Yeah, okay. Some dye now. Good. Okay.
That's pretty good. Yeah.
I'm going to cine so they can see.
Yeah.
Inject.
Good.
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 Okay. Start pacing. 120.
A little deep.
Yeah, very good.
This is good.
Look
good.
at the calcium.
Yeah, yeah. Very nice.
Okay. Stop pacing.
So we want to take the parallax out before we release. That's what we're doing right now.
Inject.
Excellent.
It's almost
I don't
zero.
know.
Maybe
It's almost
Zero
zero.
there.
Yeah. So you can see it's a little bit too high on the non, and it's almost zero on the left. So I think we should recapture.
I would go
Yeah.
to this view.
That's fine. That's why
okay?
we're saying this
yeah,
view. Yeah.
Please. Your other
Okay.
views. Okay.
All right. Ready?
We are
so
going
we're
to
gonna
capture again.
Pace.
Yeah, pace at 120. So as the valve is captured, I'm going to go in. Please don't move the camera.
Yeah, he's just centering a little bit.
Good.
Okay, good.
Some die,
That's it.
quickly die.
Good.
Okay,
Good,
went
good,
in.
good, good.
Yes.
Yeah.
Okay, continue to pay. Okay, stop pacing. It's better now.
Just leave it there.
It's a little bit better, no?
Guys, moving the camera.
No,
Leave
I
it.
tried to take the parallax out to make sure we don't have zero. Okay, good. Now we can see.
Inject.
Yeah. That's better.
That's
Yeah.
better,
Much better. Okay. All right, good. So we'll
Okay.
take the pigtail out now.
Pigtail out and pace
So
again
you
at
see
120.
that we can, the calcium at the base is paced at 120. It makes it harder to look at the bottom of the cuff. So you have to be absolutely sure that you're below the annulus, not above. Okay, ready?
Yeah.
Pull the wire back, please, Sahil.
Yeah.
So you have to pull the wire back. This is a Lunderquist. You don't want the valve to pop at this critical moment. And you go release extremely slowly, as you see here. Push a little bit forward. Okay, good.
Okay,
So
good.
excellent.
Pull back.
Okay. Pacer back up at 30, please. So this is another critical maneuver. See what we're doing? We pull back the stiff wire all the way to the nose cone. And then we actually
Okay,
pull back
I
the
would
nose
take
cone.
this wire out.
You don't want to pose, right?
Yeah,
I want to
take it
leave
off.
this wire there.
Good.
Okay. Okay.
Come on. Hopefully we are done.
All right.
Okay, let's
So-
take a look,
So
Stam.
Kini has predicted that we already done. We don't need to post dilate.
Okay. All right. You want to
All
inject
right,
now?
let's do the aortogram. No, wait 1 second. We'll do the aortogram first.
Okay.
Yeah.
Angiographic.
Good.
Okay, ready?
Yeah.
For the height and AI. Inject. Looks good.
Looks
Okay.
good.
Well,
Okay,
well,
good. Okay,
Maybe some
Stam.
AI. So diastolic was 40 before. We're
Flush it.
still
No, but you have to
above.
flush the catheter. So
Yeah.
first.
Okay, let's see on the echo now.
So you
we
can see
always
this
see
is
the
a very nice step. On the non, it's about 1 to 2 millimeters, 2 millimeters. On the left cuts, it's around 3 millimeters. So we obviously like to implant high to avoid pacemaker, but you don't want to be too high. And that's what we did. We recaptured to make sure that we're below the annulus, because you see that earlier that the calcium was at the white line.
Okay, can you put some color, please? So the valve is in a good position.
Can we show echo, please, live?
Okay, Sam, tell us.
Yeah,
Echo.
the valve is in a good position.
Can we change the hemodynamic? Can we
No
take
need
off
for
LV
hemo.
function
Echo.
is normal. Actually, hyperdynamic, small ventricle. No much AI is
Good.
in here. Maybe trivial, as you can see.
Trivial. Okay.
Yeah.
Trivial
Short axis?
Trivial PVL.
We'll take that.
This is the short axis. Put some color. The same thing around, as you can see, around 12 o'clock, minimal PVL. Okay,
Okay.
we'll take some.
I guess
long axis
we leave
for
it, right?
Yeah.
Everybody
Yeah.
agrees?
91 euro. I think this
Yeah.
is an excellent
This
result.
is a great result. Let's put some color, please, on the valve.
LV looks
Pedro,
good.
what do you think?
Yeah, it clearly
The
highlights
lights on now. We can put the lights on, yeah.
the beauty of the device, that initially by CT was as small as 4.5 millimeters in diameter
Yes.
for this valve, and now after the balloon
Okay.
and the lithotripsy was able to go through the wire with no trouble. Of
you
course,
see-
the deployment is perfect, both documented by hemodynamics and by echo.
Yeah,
So
so
I think we're done.
Yeah, I mean, our EKG has not changed at all, despite, we upsized to the 29 Evolut Pro. And so the key here is really to implant, as high as you can, close to the annulus, but not above the annulus. And this is the key. You saw that we have to make sure the parallax is removed when you deploy the valve to assess the true depth. Okay, very good. So I think this is the second part of the procedure, which is the closure.
Yeah.
It's as important as the
Very
access.
important.
So Dr. Sahil, you want to talk about how you do close the
What you're going
Let's
to
let
do
him close, then we talk.
Yes. You want to do your presentation? Mark?
Sir, do your slides.
No, but what is the plan? Just tell.
Yeah, just
so
tell.
you know, the crossover, whatever. Just say that.
Right.
And while you will do it, I'll have my didactic discussion. So what is the
Right,
plan
so
now?
we already have a crossover wire,
I just
in
help
our
you.
left
I
groin.
help.
Yeah.
We're gonna swap this out for our sheath and see if it. I won't push through if
Keep
you
going.
know
Keep going. Yeah.
we can just sort of leave it there.
Yeah.
And then we'll take it out and try to deploy our per closes. If they don't go, I usually give some protamine, and then we can use balloon tamponade from the other side.
Yeah.
Okay, good.
Yeah, use to switch the wire. Yeah.
So what percent of cases we are doing a crossover now?
Crossover rates,
It's still very high.
I would say now 30 to 40% at this point. If there's no calcium, we don't do any crossovers. If there's challenging anatomy, we keep a wire in. So
Okay.
30 to 40%.
Good. So while they're doing the crossover and the vascular hemostasis on the
Repeat
left
the
side,
ACT, please.
and the idea is just going to and then develop. We already have pre-closed sutures there.
Yes.
Yeah. Okay.
Okay.
Okay. All right. Okay. So
Yeah.
we just want to see
So
how
we
much
can go back
programming
to the
there is.
slides, and once I present my data, and we'll come back to show the last picture of the vascular hemostasis. So this, what is the discussion today is the alternate vascular access for TAVR. Now, as you can see, that we started our life with the, actually, if you remember, it was the first one was the transeptal. So integrate. The first TAVR in 2002 was done transeptal. The problem with the transeptal was it lacerated a lot of the chordae and created mitral regurgitation, so rapidly became retrograde with the iliac artery or trans-femoral. Then of course we came, then some cases where the vascular access is not suitable like this, went to the transapical. And after that, knowing that the apical had some higher problem, then the transaortic came in, transsubclavian, and now we actually have the data of the transcaval. Go through the vein, puncture into the aorta, and then close the device, the hole with the implanted device. And of course, now latest one is the transcarotid, and I'll show you the data on all. So most important is that percutaneous or PTA or cut down or intravenous intravascular lithotripsy, like this particular case, we try to go femoral. Why femoral? Because if you see the data on the partner 2 trial, remember partner 2 trial, the real benefit of lower mortality occurred in the patients which were done transfemoral, about 80% of cases. So clearly that led to the partner 3, where all cases were done only transfemoral. And there was no other alternate access for the partner 3 trial. In the Evolut, we did have some alternate access, but definitely for partner 3, all were transfemoral. So basically, this is the evolution right from the beginning to end. Of course, we have maximum experience with the transfemoral, but other, as I mentioned, the subclavian and transcaval are coming up as the alternate approaches. So now basically what we did, the lithotripsy we already have shown that it basically breaks the calcium, and of course it works with this mechanism of the cracking the plaque and able to get your big sheath in, like the ideal case which we have it here today. So basically then what happens is subsequently this is the device which we have shown you all, and the data from JACC cardiovascular intervention of lithotripsy assisted vascular access for the TAVR, prospective registry of the 42 patients and 4 centers in US, and overall showed that very good success. All patients, they were able to get in and very little complication of the device. So there seems to be that overall 4.6% access site complication, because one patient developed pseudoaneurysm, one required endarterectomy. These were all difficult cases. So therefore, I think very acceptable data of the Shockwave. Now what is happening is the alternate access. You can see here that various studies have shown that whether it's a European, UK, or our STS ACC, that transfemoral, transapical, other alternatives are really increasing, with the transapical is disappearing. You see that transapical is bye-bye. We don't use it because studies have shown having a higher trouble. And of course, these are the various, one of the studies showing the life-threatening bleeding, stroke, or mortality. Clearly the bleeding and a little more, we had to be cautious in the transcaval patient, and so on and so forth. So first one was, what about transfemoral versus transapical? We have the data from the partner 1 trial, and that basically showed that all cases, so clearly the transfemoral TAVR was superior. Every complication on the top, as you can see here, much higher. In hospital death, bleeding, renal failure was higher with the apical. So transapical became the procedure of not to do. And these are the subsequent data for and follow up to 3 years and so in the partner 1 trial. Then second, we actually have the data from our institution, which comparing the transaortic versus subclavian. Transaortic means direct aortic, and compare those cases, and you can see here again, the subclavian was superior to transaortic. These are the cases, all non-transfemoral, They were either direct aortic or subclavian, and subclavian has a much better outcome overall. So clearly, that's the second alternate strategy if the iliofemoral does not work.
Navicross.
Then question comes is the transcaval, and then how do you do it? There is by Greenbaum is the leader in this field, and they actually have shown various steps that how do you puncture through the inferior vena cava. Although you have a CAT scan, you have the area where there is less calcium, you puncture there, and you exteriorize the wire with a snare, and then you put a sheath in, and after the sheath in the bottom D, as you can see, that aortocaval access site is closed with the nitinol cardiac occluder. Biggest concern is that occluder. There is always a leakage behind happens, and that is what they showed in their data of 100+ cases published in JACC 2 years ago. But overall, at least come with the new strategy, these cases where you cannot do. And these are some case examples that they've shown, and these are the procedural characteristics, quite safe. But most important is you can see here on the right side that there is bleeding is the big concern, including the retroperitoneal hemorrhage, small group, but that happen. So clearly, therefore, I think initial enthusiasm was there for the transcaval, now kind of gone down a little bit, and the overall in the literature, because all the other alternate accesses are coming up well. So then latest one is from the French registry is the transcarotid. So appropriate cases where there is no atheroma, that can you do a transcarotid? And these are the data actually showing very good success. 30-day, as you see here, only 1.8% complication, and overall seems to be a large number of patients, about 300. All these cases were done under general anesthesia, but excellent outcome. So transcarotid TAVR will come up slowly and slowly in appropriate cases, and so. Basically their conclusion was that transcarotid TAVR using the Edwards SAPIEN 3 device was safe and effective in this prospective multi-center registry. An approach might be considered in selected patient as the first line alternate approach for TAVR, where the transfemoral access is prohibited. And key is that, of course, you need to do a more of a randomized trial and so to see this. Okay, then, so if I put it this all in an algorithm phase, that of course we go with the transfemoral first. If not good anatomy, then you go with the transcarotid, or you go with the transaortic, or you go with the subclavian. Each center has to develop the expertise on one strategy. And I think the trans-subclavian is at Mount Sinai, and many centers will have others, including the transcaval. And of course, if nothing works, then only you go with the considered transapical. And I can tell you, at Sinai, we have used transapical 5 years ago. So no transapical now. So what I've done is, based on the data, if you see here, 4+ is good, 3+, 2+ going down, and minus is the overall, that's where we are. The transfemoral and iliac artery is the best, then comes your trans-subclavian. Carotid data looks very solid, and of course, rare cases of the transaortic and the transcaval. As I said, transcaval is going like less enthusiasm because very complex and worried about the retroperitoneal. Transapical, transseptal, contraindicated. So minus, nobody uses them at present. So just to give a Sinai, last year, we are 88% percutaneous femoral, 10% were the cut down. We have only one case we did with a lithotripsy, but now we are understanding many of those cases, or the cut down probably can be done with a lithotripsy because it's small artery. And 1.4% was subclavian, and there was only one case of the direct aortic access. And there is none cases of that. So therefore, nice editorial by Thomas Modine from Europe, that alternate access for TAVI, stay clear of the chest. Don't go near the chest, just be anywhere outside, including carotid, to get your good results. So take home message, that with overall success of TAVR in all risk group, majority of severe AS are being treated by TAVR devices, and hence we need to develop expertise in alternate vascular access for safe deployment of TAVR valve. Overall percutaneous approach with or without PTA or IVL remains the best and safest approach for TAVR. And I mentioned to you already that partner 3 included only patients where they could do a transfemoral TAVR. Of the various alternate vascular access for TAVR, trans-subclavian and transcarotid in appropriate cases hold the most promise and are rapidly emerging as the viable alternate techniques. Trans-cable access after initial enthusiasm seems to slow down in adoption, most likely for the fear of retroperitoneal bleed, although small in the majority. Anybody wants to comment on that? Trans-cable, everybody was very excited a few years ago, and we don't hear much about it. You have any, Gilbert, you want to comment on the trans-cable, what is hearing in various meetings?
I think every site should have their own preferred alternative access route, whatever it might be, because there's so few now done at any center. As long as you're comfortable with that, I think that's really the bottom line.
Yeah.
Yes.
You have to be doing it a lot. Otherwise, if you do one case here and there, it will be a problem.
Like any other device, same. Okay, so let's go to the questions quickly. Following are the reasonable alternate vascular access for the TAVR except transsubclavian, transapical, transcarotid, transcable. We have made it very clear. Transapical is no. Second, following is the most important concern about the transcable approach for TAVR. Stroke, mortality, retroperitoneal bleeding, and arterial vascular trauma. It turns out to be retroperitoneal bleeding. The last one, which of the TAVR randomized clinical trial included only trans-femoral approach for TAVR? CERT-AVI, partner 2, Evolut low risk, or partner 3? I mentioned already, which is the correct answer is partner 3. They did only trans-femoral TAVR. With that note, I finished my didactic discussion, and they're still finishing their per close in this particular case, which will take a few minutes. Finish.
Close it.
Yeah.
I think, where is Pedro Moreno?
Yeah,
I'm here.
Yeah. Any questions you think you have for us?
Well, I think the case shown how easy the new acoustic device with the lithotripsy can help the interventionalists around the world. I think the only question will be, when do you think that that balloon may not be indicated? Is there any anatomy or morphology that you may be concerned to use it?
I would say that, concern basically will be, that's like coronary. There is about 5 to 8% failure rate in the disrupt study, CAD studies. So very calcific. So we actually even have last time on our December 6th case, we were not able to advance the device. So you have to dilate with the regular PTA balloon, then you advance. So only thing is the bulky device, a very tight lesion or angulation, you may not be able to get through. So you open with the regular balloon and then you go with the lithotripsy. But that will be the only contraindication for this case.
Fantastic.
For this device,
I think with this, we are going to finish the presentation today, unless there is any other issues going on with the closure, which I think is very straightforward as we see.
Yeah.
So
they're just closing.
You finish it sentence-wise, whatever.
Who's holding why?
No, I think this has become the regular TAVR cases, like everything has been discussed. Essentially, everything is becoming femoral. And, now since we have a low risk on board, I think patients essentially walking into the room, getting very little anesthesia, just do a radial access, get the sentinel up, do one, percutaneous access from the femoral TAVR, and essentially monitor for 24 hours and going home. So we are talking about 48 hours in hospital, since the risk has changed a lot. That's what we are seeing here, and that's what's going to happen. So it will become like a routine procedure, and most hospitals are trying to adopt that now.
And with that note, our presentation of today's structural webcast ends, and we'll be happy to wrap it up now and come back in 2 months.
Okay, so thank you so much for the heart team members of the Cardiac Cath Lab. And thank you all for joining us for this exciting case. Remember, the recording of this case is now available at www.ccclivecases.org. Now, the structural heart life cases of every other month will be transmitted. Remember, it's 9 a.m. Our next meeting together here over the internet is November the 12th. So remember, November the 12th at 9 a.m. And thank you so much for joining us today.